Welcome to Deep Dive Dialogue. Our topic for discussion today is advancing precision oncology in breast cancer, integrating biomarkers and personalized treatments for improved patient outcomes. The landscape of breast cancer treatment is evolving rapidly, with biomarkers and personalized medicine offering opportunities to enhance patient care. Our goal in this discussion is to explore how we can harness these advancements to not only improve treatment efficiency, but also ensure that patients receive therapies that are most suited to their unique genetic profiles and clinical needs. To discuss this topic, we have with us Divya Ujjal. Divya is a dedicated genetic counselor specializing in hereditary cancers and precision oncology. She is currently working with 4-Base Care Onco Solutions. Divya empowers cancer patients with cutting edge next generation sequencing solutions and digital health support, delivering personalized care to improve patient outcomes in the fight against cancer. So, welcome, Divya.
Thank you so much, Dr. Manisha. Thank you for this opportunity. Very excitedly looking forward to our discussion further.
Right. So, my first question is based on the latest ESCO guidelines, who qualifies for germline BRCA1 and 2 testing, and how do age and cancer stage influence eligibility?
Right. So I think ASCO guidelines that came out very recently at the start of this year have been the talk of the town, and they have enlisted a lot of new pointers to essentially include genetic testing for more and more individuals. So this is how the guidelines goes. This is how the criteria is for germline BRCA1 and 2 testing. All newly diagnosed patients with breast cancer at an age lesser than equal to 65 years and selected patients above 65 years based on personal history, family history, ancestry, or their eligibility for the PARP inhibitor therapy. That's pointer number one. Number two is all patients with recurrent breast cancer who are candidates for PARP inhibitor therapy. Number three being women who develop a second primary in the ipsilateral or contralateral breast. And number four being patients with prior history of breast cancer and without active disease. Testing should be offered to these patients diagnosed lesser than equal to 65 years again, and selectively in patients who are above 65 years if it is going to help inform personal and family risk for them. So these are the recent pointers that have been included for the germline BRCA1 and 2 testing by the ASCO. Coming to the second part of your question, which was about how does age and cancer stage influence eligibility for this test. So when you're looking for a germline variant in an individual, you are basically suspecting a hereditary predisposition or a cancer which is hereditary in nature, as we call it. So hereditary cancers are generally known to be present at much earlier ages. So the average age of onset, say for breast cancers, as we know in women, in the Indian population is about 45 to 50 years of age. But when we're talking about women presenting with hereditary breast cancer, they will typically present at much earlier ages, say in their 30s, as early as 25, 30s as well. So particularly, yes, age is a very big factor. 1 and 2 testing. Individuals who are being diagnosed with very early age in comparison to the average age of onset should definitely be offered germline testing. And as far as the cancer stage is considered, it has very less influence on the eligibility. But yes, as ASCO recommends for individuals who have recurrent breast cancer, who have developed a second primary breast cancer, BRCA testing is very, very important for these individuals. And now with the onset of targeted therapy, we're in the space of precision oncology. So with the onset of targeted therapy, PARP inhibitor therapy has become a very important name in the breast cancer treatment spectrum. So all individuals who are eligible for PARP inhibitor therapy definitely should receive germline BRCA testing.
Well said. So, my next question is that triple negative cancer, especially the breast cancer, often leads to genetic testing recommendations. How does a positive test influence therapeutic strategies?
Right. So, triple negative breast cancers, TNBCs as we call them in short form. So, most triple negative breast cancers are known to be hereditary in nature. Although I would like to specifically clarify here that not all triple negative breast cancers are hereditary. But because there have been studies which indicate that a lot of triple negative breast cancers have BRCA mutations, so this being the reason, triple negative breast cancers qualify as a very important indication to get genetic testing done. When an individual with a TNBC, that's a triple negative breast cancer, is positive for a BRCA mutation, she becomes eligible for platinum sensitive chemotherapy and also for targeted therapy with PARP inhibitor agents like olaparib and talazoparib, as we know. So yeah, that's why it's very important for these individuals to undergo testing, because the positive results can definitely shape the strategy of their treatment in a very different way.
Correct. And how do you determine whether to recommend a multi-gene over targeted testing for BRCA1 or 2? And what are the advantages of using a larger panel?
So I think this is a very interesting question, especially in today's time where our knowledge about genetics is just growing day by day. So every day we come across something new in comparison to what we already knew. And another thing that is very interesting is our Indian population or the South Asian population, to be specific, is something which is like an unexplored ground at the moment. All the guidelines, all the studies that we have generally comes in from the West, which is predominantly the Caucasian population. So even through our experience in four-based care, we have been seeing that a lot of things, a lot of patients who come out with positive genetic test reports do not really have a very, a very typical, a very stereotypical kind of a history that we've read in the textbooks. It's very surprising how, we're finding very new things, very different things, which are, in contrast to what we already know. So that's particularly a reason why I would say I would not recommend any individual to only undergo BRCA1 and 2 targeted testing, unless, of course, the doctor's aim is to only check for PARP inhibitor therapy eligibility. Otherwise, when it's the hereditary spectrum that you're trying to explore, the multi-gene panel definitely serves as the better option. Nowadays, we're also seeing involvement of so many other genes other than BRCA, which particularly there are some which fall in the BRCA pathway, which is the HRR pathway, as we call it, homologous recombination repair pathway. And there are so many others which fall beyond this pathway in other pathways particularly. So there are studies which are emerging, which are particularly talking about these other genes. To mention some of these genes, PALB2, BRIP1, CHEK2, ATM. These are some of the genes that fall in the HRR pathway, which particularly mimic the clinical history like BRCA. But then you see, if you're doing a targeted testing for only BRCA1 and 2, there's a very high probability that you're going to miss picking up mutations in these important genes too. So a multi-gene panel definitely is the way to go. It's going to help us know more. It is going to help us look at the other genes as well, look at the other syndromes as well. And in contrary, some of the audience might, think a multi-gene panel sometimes is, the biggest problem that an individual has. That's because there is a possibility of stumbling upon a lot of variants of uncertain significance, as we call it. So VUS. These are basically variants which, as of today, we do not really know what they mean. We don't know if they have any connection with hereditary cancers, or are they just normal changes or polymorphisms, as we call them. But I think the solution to this is a detailed genetic counseling session. Once an individual has a consultation with a genetic counselor, which is the pre-test genetic consultation, wherein before doing a test, the counselor can take a detailed history, detailed personal as well as family history from the individual. We can also then, try to see or enlist the syndromes that we are trying to suspect in this particular individual. And based on the same, we can ask the concerned laboratory where we're sending the test to only look at those specific genes, and whatever other genes are included in the panel which are not really related to the patient or the family's phenotype can be listed, say, on the next page as an additional column listing the variants of uncertain significance. So this is particularly what we're doing in 4-based care as well. Uh, we've seen this has helped a lot, especially in making interpretation of these reports, reading these reports easier for the patients as well as for the clinicians. Even our oncologists get very baffled when they come across these viewers, because it becomes a matter of too much anxiety for the oncologist as well, because the patient is going to come ask hundreds of questions. What does this mean? What am I going to get? What will I do? And the oncologist sadly will not have answers to this. So this particular style of reporting, I think, takes care of the fact that everything that is being checked for is there on the report, but just the way it's being reported, where you mention everything that is very much important to the patient's phenotype, to the family's phenotype on page number 1, and then all the other VUS, especially, which are not really correlating with the patient's phenotype, can be mentioned as a separate column mentioning the additional variants which have been identified. And of course, these VUS can be looked up every 6 months to check if there is any research and development which is happening on these particular variants. Has the classification changed? Have there been any more studies? And that should really be helpful in a way to, make like a trajectory to how to go about further for the end users particularly.
Fully agree. Variants are evolving, and so are we. So, what genetic consideration apply to men with breast cancer, and what testing protocols are suggested for them under the new guidelines?
Right. So, male breast cancers, as we know, is very rare in itself. In fact, a lot of individuals that I counsel with BRCA, and when I tell their family members that males could be at risk of breast cancer, there's like a question mark on their face. I mean, is there something wrong in what she's trying to say? Has she made a mistake? But no, male breast cancers do exist. Yes, they're very rare, and that's why maybe very few of us who are not from the medical background know about male breast cancer. But when there is a diagnosis of male breast cancer, genetic testing becomes very crucial. Again, not all male breast cancers are hereditary in nature, but most of them can be. The most common genes which cause male breast cancer are BRCA1 and BRCA2. The testing protocols for males remains the same as females, and the new ASCO guidelines that we went through in the beginning of the session, basically they hold true for both males and females. So that's like the protocol that we follow for males as well. There's nothing very different. But yes, the moment you hear male breast cancer, genetic testing definitely should be a part of the strategy that we're following for this particular patient.
Right. And what I believe that patient education and awareness is very important. So, as an expert, what tools or programs do you recommend to help patients understand their genetic test results and make informed care decisions?
For understanding of genetic test results, firstly, I always recommend a genetic counseling session, a post-test genetic counseling session, as we call that, which is being done after the test results are out, is very, very important. Because nothing better than an interaction with an individual who has an expertise in interpreting and efficiently communicating information regarding genetic test reports to the family. I have always made it a practice to give a personalized clinical management plan to my patients. So what happens is, as a layman, it's very difficult, firstly, the receiving this particular information can be a setback to an individual, because we're basically telling them that they're going to be at high risk of certain cancers for their lifetime, right? And then with that, when you discuss what are the steps that they can take, what I believe is, in that moment of shock, there is very less retention of information which is happening. Plus, being a layman, it can be very difficult for an individual to remember these tests, remember the duration and how much time they should be done. That's why I think it's very important that all of this should be given in writing in a very systematic manner to the patient. Of course, we try to make it in a very layman language. We're following the same practice in four-based care as well. In fact, in four-based care, we're also giving a pre-test counseling summary, because a lot of times individuals, are a little, I don't know, the doctor sends some test, but I don't know what test it is. I don't know what that test will do to me. And for them, the counseling session, it feels like it's just a part of the protocol. It has nothing for me particularly. There are very less individuals who actually come up with, bunch of questions. Maybe the, say, comparatively educated lot. So what we do is we particularly, also make it a point to give the pre-test in writing, so that the patient is actually empowered with all information that they should be, and they have everything that they want to know about the test right before the test. And then it becomes a lot easier to explain the reports also, because they already have an idea as to what we were trying to look for, what could have come out. And then we give them this management plan, which is basically using guidelines from professional organizations like NCCN, ASCO, ESMO. So we personalize each of this plan to, the patient who has been detected with this particular mutation. The personalization is particularly also needed because certain individuals come to us at a later stage to do a genetic test once they've already undergone a lot of treatment. Say surgeries have already been done. So at that point in time, risk-reducing surgeries or surgeries which are being done on prophylactic basis, removal of an organ to completely mitigate the risk of cancer in that organ, such kind of recommendations are not really required for these individuals because they've already gone through that. So that's also where the personalization plays a very important role. Now, other than this, as far as resources are concerned, there are a lot of educational videos and blogs available giving information regarding genetic testing and results, which are available on the internet. At four-based care also, we make a lot of them. They're available both on our LinkedIn page as well as on our website. And in particular, if any patient has doubts regarding certain aspects, like what are the side effects of surgery to reduce risk for the ovaries, or what are the side effects, or how is a breast reconstruction surgery done, or how do you do self-breast examination. For these particular doubts, I always make sure that I myself provide the resource to the patient. As we know, the internet is a sea of information, and a lot of times there can be half knowledge based, harmful information, which is not right information for the patient. So in such cases, I always make it a point to, do my own research and always give them things from authentic websites only. So yeah, that's how we generally guide patients with the genetic test results.
Thank you so much, Divya, for this valuable insights, and let's continue advancing precision oncology to provide tailored, effective treatment for every breast cancer patient. Thank you so much for joining us.
Thank you so much, Dr. Manisha. And I think this is also going to serve as a very important resource for our patients in the future. So glad we were able to do this. Thank you so much for the opportunity. Look forward to speaking to you. Thank you.
Thank you. Bye-bye.